Thanks, Alice. Hello, everyone. I'm Anna. I'm the Head of Support Services at Ovacome. So just to say to you that if you have any questions after the webinar, or if anything comes up for you in the time afterwards, or if you have any questions or need any information on anything at all, really, then please do get in touch with us at the support service. It will be me or my colleagues Julia and Laura that you would speak to, and we're available via phone, text, instant chat through the website, email, and Skype. So any way that you prefer to communicate with us, we're available for you. And please do get in touch. We're always happy to hear from you, and we're available Monday to Friday, 10 a.m. to 5 p.m. So I'm delighted to welcome Julia Pugh, who is clinical nurse specialist in gynecology and psychosexual therapist. For today's webinar, Julia's a member of our medical advisory board, and we're really lucky to have her expertise available to us. I know that this is an issue that is really important to a lot of people. So please enjoy the webinar, everyone. And as Alice said, do submit your questions. I'll read them out, but they will be completely anonymous. So whether you do it in the chat to just the panelists or via the Q&A, I'll mention the question, but nothing that will identify you at all. So any questions, then please do let us know. And I'll hand over to Julia. Thanks very much.
Thank you. And I want to say thank you for inviting me, and I'm delighted to be able to talk about this. In my role as a nurse specialist, I obviously hear a lot about patients' concerns in this area, and I hope that today is something that's useful and helpful for many of you. And I really am interested to hear your question. There's never a stupid question, but hopefully as we go along, some of the simple things that can be answered and support offered hopefully you'll get from today. So in terms of what we'll be covering, firstly, I want to talk about what's changed. So why is your intimate lives affected by the diagnosis and treatment that women have had? What are the common problems? So hopefully that will help us understand and structure a little bit of what I can offer in terms of support and advice. What is the sexual response cycle? So how this sort of brings in both the mind and the body. So as a psychosexual therapist, that word for me is about understanding both the physical and the psychological and how they interact with each other. And it's really important that we don't leave one out. So often we get a bit fixated on physical treatments as clinicians, but for me, it's very much about putting those two things together and looking after both of them. So lots of hints and tips as well as we go through. Menopause, no talk around sex or sexuality would be complete without a discussion around menopause and HRT and things like that. Vulval and vaginal health, so we'll talk about that. I'm a real advocate for helping people understand a little bit more about how they can look after their vagina and their vulva. And partners. Often partners are missed out when we're talking about this sort of thing, and hopefully I can share a little bit of what I understand about how partners think, or what some of their worries and concerns are. And perhaps there's some partners listening as well, and this will speak to you and hopefully support you. And communication, it's always about how we communicate with each other, but also with ourselves, how we speak kindly to ourselves, that element of self-care, but also being able to understand and communicate our needs as well with clinicians as well as with partners, and learning something new. So hopefully there'll be a few things to learn here, but really it's about how we navigate learning new things, and particularly around sex and intimacy. It can feel very awkward and embarrassing to learn new things. So I hope that I've got some skills there for coping with change, and then lastly, where to find help. And so there's a few pointers at the end for that. So what's changed? In my experience of working closely with the medical team, the surgical teams, and the clinical team, the clinical oncology teams, there's often a raft of treatments that are used for women who have an ovarian cancer. And all of them have an impact on your sex life, or how you think and feel about yourself, also your body, and the changes that might go through as a result of the different treatments. So firstly, a diagnosis in and of itself is a life-changing event. It changes your relationship, it changes the role you have, potentially your work, and it's just a an understanding of your own sense of mortality that is huge. Radiotherapy, sometimes used and can cause a number of different changes, and fatigue is generally one that I hear a lot of. I'm just tired, I'm just knackered. And I think that that is, really hard when you're trying to put in new energy and to thinking about these sorts of things is difficult when actually just the day-to-day of getting up and getting the normal things that you need to get done is tiring. So I never underestimate the issue of fatigue and how much that can impact on how you feel about yourself, but also your enthusiasm for various different life activities. Chemotherapy, so many of you may have had chemotherapy and still have some of the side effects from it, even if it was some time ago. The one thing that often I get asked is around infection. So, people get really concerned that, especially if you hold a view that, sex is dirty, or that it could cause more infection. We get a lot of information about sexually transmitted diseases. And more than that, as clinicians, we talk about contraception all the time around chemotherapy, and that can be really off-putting if you haven't used contraception for a long time. It's almost like a big sign up saying don't have sex because we're talking so much about being careful and being safe. So it's important for us just to break some of the myths and the barriers down about what we talk about. So it's absolutely fine to have sex whilst on chemotherapy. Not everybody wants to. There is generally not any increased risk of having sex as long as you're safe, and on all the normal ways in which you would protect yourself. Hormonal changes, so these are huge, and for women who, we're going to talk about menopause, but for women who've gone through a surgical menopause, these changes can be quite sudden and overnight in terms of the hormonal changes and the vasomotor symptoms and the hot flushes and things like that people experience. Mood swings, I think, is a real challenge, and people often sort of feel quite negative about. I hear women talking quite negatively about themselves and how they're just a really difficult person to live with now and that sort of thing. And hopefully we can think about how we try to do a bit of that self-care, time for yourself, in order to help feeling a bit more positive about yourself and a bit more likely to want to engage in an intimate experience. Surgery, so many people will have surgery, and that can give a whole raft of effects, and so some people will live with stomas or scarring, body image changes, but also nerve damage changes as a result, and I'm going to talk more specifically about that in a bit. But overall, the most significant thing that has changed is where you thought you were going to be. So where you thought you were going to be at this point in your life has changed, and the road ahead has changed because of the life-changing diagnosis that you have, or people or women that have. And so that's a really big thing, that can be just as scary and influence how you think and feel about yourself, how you think and feel about your relationship, or how you think and feel about a new relationship as well, if you're not in one now. So this slide is actually taken from what words that women have given me to describe what's changed, and what's changed about how they feel about themselves. This is a slide, I would describe this as kind of body awareness, body image, a sense of bringing that element of what you think about yourself or your perception of yourself, as well as the physicality. So we all know body image isn't just about your appearance, but it's also about your sense of health and vitality. The word trust has come up quite a lot with women because it's a sense of, especially if you were diagnosed without many symptoms or preceding symptoms, it can be a sense of, I didn't know this was going on in my body, and now I'm not really sure that I can trust my body. In the same way, control has that influence on how we think about our bodies. We suddenly don't have as much control. For women who have stomas, as an example, don't feel that they have that control over their bowel function in the same way. And those can significantly impact how you think and feel and how you engage with your body. And there's something key here about sort of disengaging with parts of your body as well. And we use a word called disassociation. So especially when you've had lots of investigations or surgery, you start to disengage from parts of your body that have been interfered with or prodded and poked. And it's thinking about those through those things that helps us to look to the solutions for that, which is about re-engaging and the kind of thinking more kindly about yourself, thinking about things that might make you feel more feminine, you know, especially if you've had hair loss through chemotherapy as an example, or using certain things to mask stomas when you're wearing less clothes, shall I say, and other things that kind of make you feel as who you are, not just you know, not a patient, it's important that we reconsider and reconnect with a sense of you as a person and as an individual. So this slide is talking about how you kind of go from this sort of sense of survival. So if you imagine that picture in the top, I don't know which side it is on for you, but in the fight or flight. So we have this idea that actually when you're diagnosed, when you're first like going through treatment, or when you start a new treatment, you go into this, you know, life is just about survival. It's not necessarily about thinking all of the other things, thinking about this, you know, metaphysical bedroom that we've got down here. You're not thinking about, you know, date night or all the nice things that you might do to sort of re-engage with who you are or reconnect with your partner. It's actually very much about survival. And so this slide is just a reminder really that actually please do not disturb has two meanings. It has the meaning about, you know, that you'd hang on your hotel door hanger is, you know, is about don't disturb, we're getting on with something else here, but it's also about this isn't right for now. And it's just giving people permission, whether you're a partner or a patient or somebody else who's affected by ovarian cancer, that, you know, there are certain times that it is right, and it's about knowing when it's right to engage with this conversation, and also it's a journey. So thinking it through for yourself. So these are some of the common problems that I hear. It hurts, pain is, you know, rubbish, and many people experience pain in general anyway because of the types of treatments that they've had or the symptoms that they're enduring. And actually, if you begin to have some sort of sexual intimacy and it begins to hurt, you know, most people, we're hardwired to run away from pain. So, you know, it's an understandable reason not to want to engage. And if it's hurt once, you just don't, again, coming back to that trust, I'm not sure it's going to be okay again. And so you start to withdraw and retract, and it's hard to know when you want or feel empowered to start engaging in that process again. So I should be grateful I'm alive. How can I ask for more? So this I hear a lot, not just from women, but also from men who I work with from a psychosexual point of view. In any time that you've had a life-changing experience and diagnosis, this idea that actually, how can I begin to talk about my sex life with my clinicians when, you know, they're giving me life-saving, life-preserving treatments? And I think it's really, it speaks to us as clinicians that we should be supporting people and looking at people as a whole, and empowering you to have that conversation, but also acknowledging and recognizing that our treatments do affect you and your sex life and a sense of who you are, and therefore we should be talking about it. We should open up the conversation with you. So I appreciate that is sometimes a stumbling block to even begin to talk about some of these questions, even to ask if we connect the first two together. You know, I tried to have sex, it hurt, and therefore I didn't have sex again, and I can't talk to any of my clinical team about it because I don't know how to bring up that conversation, and I don't think I should be asking about this. And so I really want to say to you, if that's what you're thinking, please ask, please get help, because there's certainly some really simple things that we can do. So I'm not interested, but I want to be. So this idea that actually you feel like, you know, your sense of interest, or even, you know, you've tried to get into a situation where start to become aroused and you just don't feel it. And this idea, but actually I think I want to, but I just don't know. And I think that speaks to that previous slide around please do not disturb. It's about knowing when's the right time, and hopefully I've got some hints and tips as we go through about how to tackle that particular issue. So I've been sewn up. So this is about, I hear a lot about what worries and concerns that women have about the type of surgery they've had. You know, what's been done to them. Have they got a big gaping hole in there where things have been removed? So I'm going to talk a little bit about the surgery just briefly, because if you have got some ideas or thoughts or worries about what's happened or what has been removed, what hasn't been removed, what's been done, then please speak to your clinical team, because it's often an easy way just to allay some worries and concerns. We've tried, but it was a disaster. I think that's self-explanatory. And, you know, as I said before, you know, we're hardwired to walk away from anything that's rubbish and disappointing. So, you know, if you've had a difficult experience, or it was embarrassing, or, you know, something awful happened, then you're unlikely to want to go back into that metaphysical bedroom that we talked about. And we'll certainly hope to give you some hints and tips around dealing with that. So I don't feel anything down there anymore. It's not mine. You know, if everybody else has been prodding and poking and all of that sort of thing, if you've had any wound infections or anything like that, often, you know, the genital area just doesn't feel like you own it anymore. And so some of the work that we do is about re-engaging with your body and reconnecting. And this one, if I can't, they'll eventually get bored and leave me. So this is about relationships and the worry and fear around relationships ending as a result of intimate lives being disrupted, or there being a hiatus. And I think this is really important to hear. And if this is something that you're concerned about, hopefully some of the tips that I'll give you around communication will hopefully help to address that. But it's something I hear from people who are in relationships for a very long time, have been in a relationship for a very long time, but or equally people who are wanting to get into new relationships as well. So this isn't unique, and it's very much something that I think we need to be mindful of. So hopefully that helps to understand a little bit about what some of the common concerns are. And if I haven't talked about that, but one of your concerns, then please do write a question to us. So this is about surgery. So you've got the side view of the pelvis. I always try and do a little bit of education, just in case. Perhaps many of you know this, but sometimes people don't like to see this sort of thing. So I apologise if that's you. But this side view, I think, is really helpful. And I use it to explain to women that, you know, where the ovary and the bladder has been removed, sorry, the ovary has been removed, it sits right on top of the bladder, which is often why women get a lot of bladder concerns as well. And behind there is the rectum, that back passage, and that's also why everything's in such close proximity and everything's jammed together that, you know, sometimes if you've got bowel problems or you've had any surgery there, it can be really difficult and preventative as well for having sex, enjoying sex. It can induce pain in other areas. So being mindful of these things, if there are sort of common or consistent things that are coming up for you, it might be worth speaking to your clinical team about it and just saying, I wonder if there's something that can be done. And certainly it's helpful just to appreciate, you know, if you are having a difficulty with your bladder symptoms or your bowel symptoms, that's going to potentially be difficult, create some difficulty in having penetrative sex as well. And then this other one, which is just about your organs. I mean, nobody really looks like this picture here, but it's just helpful to understand some of the lymph nodes, the tiny little ones that kind of that are going around your pelvis, but also just to recognize sometimes how small the uterus is, so the womb is, where the cervix is. So you've got your vagina, and then you've got your cervix on top, and you've got your uterus above that. So for many women, they will have their cervix removed at the time of their hysterectomy. So all of those tissues are taken away. And then the top of the vagina is sewn up. Now, For some people, that you will read in the patient information that there's a shortening of the vagina. And some people have, again, these thoughts and ideas about concerns that the vagina is therefore too small for penetration, and there might be an obstruction there, or it's almost like that comment about it's been sewn up completely, that penetration isn't even an option. I just, want to explain that the vagina is very stretchy. If you imagine that if in normal birth, the vagina would stretch out so much that a baby's head can come through it. So, it's incredibly stretchy material. So there really shouldn't be a reason that that penetration isn't possible, even if there has been some vaginal shortening. However, everybody is an individual. And again, if you're having problems, you're not sure about things, then please speak to your clinical team, because sometimes an examination, I can't tell you the times that I've done an examination on a woman and then she's gone, oh, I feel so much more relieved, I know things are okay. And if that's what you're thinking, you're worried, please do go and get an examination, because that might just alleviate some of your concerns. So I hope that's helpful. Okay, so this is some of the nitty-gritty around sexuality and expression of kind of sex and intimacy. So there's lots of different models around that we can consider when we're talking about this, but this is my favorite model by far, because it's purely about a satisfying experience. It doesn't mean that you have to get to orgasm. It doesn't mean that it has to be about penetrative sex. It's just purely about having a positive experience. So if you've had a positive experience, you're much more likely to want to start that cycle again. And that comes back to those common concerns about if it hurts, you easily stop going through this process. So you start from the top. It's a process, not a performance. That's always what I say to people. You start from the top. You're in a place where you're not thinking about sex, so you're sexually neutral. You're not thinking about it, but you're not put off by it. So if you've got a lot of abdominal pain, you're probably not thinking about, you're probably the other way. Yeah, you're not sexually neutral at that point. Or likewise with the emotional intimacy, that you're feeling safe, and sometimes that goes back to that fight or flight. If you're in a place where you're just highly stressed, you're anxious, you're worried, there's an awful lot going on, you're struggling with the day-to-day, then really it's a hard time sometimes to get into a place where you feel emotionally available to kind of start this process off. So you start in that place, then you kind of, hopefully you're feeling in a good place, a positive place. You're not thinking about it, but you're not thinking about too many double negatives, sorry. And then you move on to kind of something sparks some interest. Now, I say to a lot of people, this is often a birthday that's coming up, or some sort of other, occasion or scenario, a holiday or something where you would normally have had an opportunity or be thinking about an opportunity to be intimate. And that can be a whole raft of things, and it's very individual. So and it can often just be a point of communication between you and a partner, or if you're in a new relationship, potentially those sorts of things as well. But the next bit is about the body and mind working together. So that biological, psychological factors all coming together. So you're interested, your body is in a place that it's going to be receptive to that stimulation. And really that those factors all influence together. So your body and your brain are all in synergy. What often happens at this point is your brain's going, oh my gosh, no, do you remember the last time? It was awful. This is going to hurt. And it's easy to kind of exit at that point. You just want to kind of, you've sort of walked out of the room at that point. And so it's just being mindful that you can actually start to switch off those thoughts and ideas and just be present with what's going on for your body. Slowing things down is really important. So it might be about spending some time relaxing and enjoying being in a relaxed state is a really good starting point. And then sexual arousal. So that's that point where the two things are coming together. So you're relaxed enough, you're listening to and being receptive to the things that are hopefully pleasurable, and that sexual arousal arises. Now this could be a kiss, You know, this could be, you know, something as simple as hugging and being together, or it could be obviously on your own as well, being relaxed, being receptive, listening in and tuning in to the things that you're finding arousing. And then as you stay in that place, in that mind-body connection, perhaps you have more sensation, more interest, the arousal increases, and then so does your desire for more. And this is where you hopefully end up in a place where you're satisfied physically and emotionally. So you may not come away from that experience having had an orgasm, or somebody else having had an orgasm, but you actually just feel better. You know, you feel like you've connected with that part of yourself, and you know, and that has been a positive experience. One of the reasons that I like this model is because sometimes I think people think that you have to start from a point where you suddenly feel really interested in sex, and that sex drive, or libido as some people describe it, is the starting point. And I wouldn't necessarily say that's the case. I would potentially offer the idea that actually you can start this, you can be proactive, if you like, by saying, actually, I want to commit to this part of my being, or my relationship with myself. And so I'm going to set aside time in order to be able to do that. And so that leads us on to thinking about, how do we do that mind-body connection? So I'm sure you've heard a lot about self-care. Hopefully, if I know that there's lots of information out there about women looking after themselves, and mindfulness is a term that's bandied around a lot, but for me, all it means is being body aware, but also being mind and body connected, trying to stay in the moment, being receptive to the sensations that you're having. And breathing exercises can be a great starting point, just to reconnect with what that feels like. And setting aside time. So I put timetable on there because timetabling, or putting that time aside for you, for your relationship, is often something that's missed. Previously, you may have just scooted it in somewhere, somehow, but actually, you know, things have changed. There are more barriers to the sorts of experiences that you might want to be having. And so you've got to set that time aside in order to be able to do that. In order to be able to engage, in order to be able to calm, you know, be relaxed and be positive. So I know this slide is interesting, isn't it? Because it has scarring and stoma on the other side, because I often think that people, you know, immediately come up with those worries and barriers. And so if that is you, there is, it's important that we address that. And I'm certainly not somebody that says just, you know, just deal with it. There are lots of ways that you might want to work with somebody to help you understand, what is it about the stoma that's such a big barrier, or what is it about the scarring. And there's some simple things that you can do, underwear, or ways to change things so that you understand, or you feel more comfortable or more confident about engaging in intimacy, or just purely being you know, naked is really challenging for some people. And so working with that, and just remembering that there are small steps. And then this lovely picture, I really like this picture of nipples and boobs, because it's actually about recognizing that it's not all about your genital area. There are lots of other erogenous zones on your body that you can engage with. And so, you know, even if it just feels too scary, too overwhelming to even consider intimacy in terms of doing anything in the genital area, actually there's lots of other ways that you can feel those sensations, engage with that part of yourself. So I hope that's helpful. So menopause, so menopausal symptoms. This is I like this poster. It's a really good poster that sort of captures everything for us. The biggest thing that I will say is that it's what's right for you. Not everything works for everybody. It's a bit of trial and error. And one lady's hot flushes are manageable for her versus another lady's hot flushes that are completely disruptive to the day, the night, and everything in between. And so it's really thinking about, what are your, you know, if you're not coping, if you're not managing, if that's not, that shouldn't be a negative thing, you should seek help. And I really want to acknowledge that it's not the same for everybody, and we really need to, as those in your clinical team, really to support you with what we can do. There's lots of different strategies out there that CBT has been more recently done, and actually I did see the a wonderful menopause doctor who did a webinar for you guys, so perhaps you can listen to that if you haven't already. I think one of the key things is, you know, worries about evidence and HRT, and just women put up with a heck of a lot. And so, you know, there's, for us, obviously everybody's individual, and I'm not going to make any sweeping statements, but we have got a lot more confident and a lot more patients that are happier, because we've got an evidence base now that tells us that HRT, the majority of the time for women with ovarian cancer, not all, but for the majority, is safe to use. And if it's going to help you have a better lived experience and quality of life, then that's absolutely something that we should be considering, but working with you about. So I would be clear about opening up that conversation, about talking with your clinical team about it, about maybe doing your own research, especially if they're very anti or negative. It may be that there's a lot of evidence out there that you can share, and it's got to be right for you. I know that there's a lot of anxiety about that, but I sometimes spend quite a bit of time with women and partners, you know, talking through these issues and really thinking, if that is still something that you're concerned about, what is it, what are your levels, you know, what can you cope with, what can't you cope with? You've got an awful lot going on. So if this is something that we can use to help your life be better and your quality of life be better, then we should absolutely do so. I hope that's helpful. Okay, so vulval and vaginal health. This is something I feel really passionate about, because I think that we miss, sometimes we do a lot in terms of our facial care. We know what it's like to have a routine for looking after this very precious skin that we have on our faces. And the same is true for our vulvas. And for women, so the vulval area is what this picture is about. It's all of the outside, everything that you can see on the outside, that's your vulval area. Now, what's important is that skin is served by the same estrogen that keeps the health of the tissues as would be from the ovaries. So if you've had a hysterectomy, if you've had ovarian cancer, if you're postmenopausal, you're going to have less of that estrogen that keeps the health of the vulval tissues as well as the health of the vaginal tissues. So we remember that slide before, we've got a vagina that sits above this, if you like, and you know that what happens is that we get vaginal dryness, and that can cause a lot of discomfort and pain. And so what we want to do is address both. So vulval health, we're looking at washing. Now, people get really have very different views about this, and I do understand that, but we talk about washing with a soap substitute or water. And the soap substitute being the dermal that I've put at the bottom there. It's not the only one, there are others, but I would steer away from the ones that have got a lot of perfume in and that are on the sort of shelves. So this dermal is an oilatum. It can be used as a soap substitute, and it's also got an antimicrobial agent in it, so it's absolutely safe to use on the vulval area. But if you don't want to wash with that, water is absolutely fine, and sometimes people use saline, so water with a tiny bit of salt in it. But any other sort of washes, definitely not shower gel, definitely not a bar of soap, but just to make sure that the skin is nice and washed on the outside. But also moisturizing inside, so in the vagina. So there's some vaginal moisturizers here at the bottom of the page. These are all non-hormonal. So Yes is a great one, which is, they also do lubricants, which we'll talk about in a bit. Silk is another one. These are also available through your GP. And then Hyalofem is one that has actually been in trials against topical estrogens, so vaginal estrogens, and has been shown to be just as effective. So it's a non-hormonal base, and it's up into the vagina to keep the health of the vagina, the tissues nice and healthy, and that helps with this elasticity that we talked about before. And it also helps with kind of avoiding abrasive type feelings. So women will describe to me vaginal dryness feeling like sandpaper inside, or sometimes barbed wire or broken shell. And it's, if you're experiencing those things, then there's some really, these sorts of simple measures will really help. So what we tend to recommend is washing on the outside, moisturizing on the inside, but moisturizing on the outside as well. And doing this and as a kind of maintenance, really, to keep the health of those tissues. So over time, you know, this is about avoiding problems. So a lot of people will say to me, well, I don't have any problems. That's great. But what we want to do is avoid any problems in the future as well. The other reason that I am a real advocate of this approach of maintaining and engaging is because sometimes we don't really know our own anatomy. We don't know what feels different. We don't look down there. And it's sometimes a really important way in which we can actually start to re-engage with our own bodies and hopefully understand a little bit about where the sensations are. Has there been is there sensations? Are you beginning to feel sensations again? And that can be really valuable as well, as you can kind of commit to re-engaging with this part of your life. And that leads on to lubrication and pleasure. So just making the really succinct point that lubricants are for intimacy. So they're not there to moisturize and maintain the health of the vagina or the vulval area. They're there purely to reduce friction. So you've got water-based lubricants, oil-based lubricants, and silicone-based lubricants. So water-based are excellent. Oil-based are you know, water-based most people can use. Oil-based you can't use alongside condoms because they denigrate the latex. Silicone-based are often what, you know, some of the longer lasting lubricants are made from. And there's a range of different ones. And I know that you've had a chat from Samantha from Joe Devine talking about the different toys as well. And it's really important that, you know, we think creatively about different ways and changing things as well, and rediscovering what's actually enjoyable or pleasurable. And especially when penetration or the sorts of sexual activities that you might have had prior to your diagnosis or prior to any of your treatments have changed, you actually want to think about well, what else could we do? What else might be enjoyable? What else might I enjoy? And particularly if you're starting a new relationship, you want to, you know, be helping to guide and direct that as well. So I've put on there a couple of different lubricants, but there's plenty out there that you can try. So this leads me on to just thinking about partners then, and I think that sometimes partners are missed, as I mentioned at the beginning, and perhaps there are some partners listening. And these are some of the things that I've heard from partners around things are different. I should say she's more fragile somehow. I'm embarrassed. Nobody talked to us about it. So again, if nobody's actually saying this is an area of your experience or your journey that's likely to be affected, we can help you with that. It feels like it's a silent, there's, you know, sort of a determined silence in it all. It's just too difficult to talk about. So often people have been together a really long time and then still struggle to talk about these sorts of intimate things and how you might navigate. And the one big thing is, I don't want to hurt her. And it's actually just really, sometimes if the partner is feeling that, then you kind of start to spiral into this negative place because the partner doesn't want to hurt you, therefore there's no initiation of any type of intimacy, and you start stopping the normal things like kissing and holding hands perhaps, or even being close, or even sitting next to each other on the sofa. And therefore the person themselves starts to feel unwanted and you know, oh, I mustn't be sexy anymore, and that feeds in. So there's a lot of that kind of thing that's going on that we just kind of need to voice, communicate. What are your worries? What are your fears? What is concerning you? And even just starting from the place of partners saying, I still feel like this, or new partners saying, I am in this new place, I'm not sure, this is going to be difficult for us to navigate. I wonder if we can do that together. So that leads me on to the communication slide. So basically you have two options, communicate or miscommunicate, and we're really good at miscommunicating, but sometimes really struggle to really articulate what we mean, share what our wishes and desires are, and hear that back. So There's lots of really good, quick communication skills and core skills and tools that you can use in terms of communicating with your partner, but also it's about listening and tuning in to what you hear in yourself say. So perhaps for those of you who've maybe done a bit of this in terms of supporting and self-care, it's really tuning in. What am I hearing myself say? Is that a kind thing to hear myself say? What could I replace that with? So sometimes it's quite negative things about body image. Sometimes it's so focusing on the negatives rather than focusing on the positives. And you know, that all of this sort of, sometimes if you don't communicate well with yourself or with a partner, then you just get into this space where you're just mind reading. Well, he's not interested because they've not done this, or she's not thinking about it, or she must be feeling uncomfortable and not interested because of everything that's going on, and it just leads to all of this avoidance, and then sometimes resentment, frustration, and you don't get anywhere when you're in that place. So I've put on the other side of this slide about date night, and that is date night with yourself, date night with a partner. It's just setting aside time to you know, think about this if this is something you want to commit some space to, and hopefully improve things. So learning something new. So we're coming up to the end of the presentation, so please do write any questions down if you've got any. So learning something new. So these are kind of strategies, skills for coping, skills for that adjustment that we're talking about. So things aren't going to be the same, and you know that there's a new place that you want to get to. So how do you get there? So being mindful of, actually, you've got to give yourself a bit of slack and put yourself in a space where you're learning something new. When you learn any new skill, you've got to start, and I call it training camp for people, because it sort of resonates, the idea that you're not going to get it right at the start. You can have a bit of a giggle, you can have a bit of a laugh, you can get some lube out and have a joke and things, and just trying not to take yourself too seriously. Keeping that open communication with partners is really essential. How's it going for you? Are you interested? You know, that sort of thing. And also focusing on self-esteem, not the perfect body. So, you know, I mentioned before about sometimes we can get very fixated on the things that we don't like about ourselves, or I've got no sensation down there whatsoever, I don't even want to touch down there. That's what I hear a lot of women say about their genital area. Thank you for all that information, Julia, about vulval and vaginal health, but I will not be going there at all. So we talk about what other areas of their bodies do they like, and how might they engage and start to get some sensation there. And it's sharing responsibility for sexual initiation. So, you know, it is really important, especially if you are in a new relationship as well, about sort of, you know, sometimes people have fears about somebody's, you know, approaching them and then not really knowing what to do about it, but it's actually sharing that responsibility. Likewise, in a long-standing relationship, you know, it's also about saying, actually, we've both got some responsibility here. And so sometimes something around date night can be quite useful, because then it doesn't mean that somebody's going to sort of be in the wrong frame of mind, or you know, rejected. That's a big concern for people. And substitute non-penetrative sexual behaviors. So all the fun things that, you know, think about times that have been good that you would like to do again, or new things, some of which you might have seen on here, and just broadening your ideas and thoughts. So if you want to get help in this area, and you feel like some of this has hopefully been a bit helpful in sort of thinking about some of these concerns, but you actually want to get a bit more help on that, there's a few different ways. So there's person-centered counselling, which you may have heard of, which can be really useful in terms of just kind of honing into what are the worries and concerns that you have, what are the barriers. And, you know, when women are experiencing such a difficult time in their lives, this is not always at the top of their priority list. And so other things need to be sort of supported in terms of that adjustment, in terms of understanding and processing the new place that you're in. Likewise, cognitive behavioural therapy can be really useful and beneficial, especially when managing symptoms or concerns, and that has proven to be really helpful in the context of managing menopausal symptoms. Psychosexual therapy. So there are a couple of different ways that you can approach that. You can get a GP referral for any of the above, but psychosexual therapy will be just focusing on this sort of element of things, and can be really useful both as an individual but also as couples. And so finding support, so if you're looking for a particular therapist, then from a psychosexual point of view, you're looking at the Institute of Psychosexual Medicine or the College of Sex and Relationship Therapy that you can do online, and both of those have find me a therapist type thing. Likewise, I said, you can go to your GP. Online, the Sexual Advice Association is actually an app, so you can take different tests and you can get some advice and different things. And I've certainly known different people and women and partners find it quite useful, because it's about just making things a bit more normal. Like how do you navigate this particular issue, or if you've got a particular symptom, knowing that it's not, you know, a terrible thing, or having an explanation or some understanding, some education behind it is really helpful. And charities, wonderful charities like Ovacome and others who are creating the space to talk about this stuff, because it is what we need to be addressing in order to help make things better for people. So thank you for listening, and I really look forward to hearing your questions.
Thanks ever so much, Julia. And I'll just pop in the chat for everyone just links to our previous webinars, which includes the 2 talks that Julia just mentioned about menopause, and also from Sam Evans at Joe Devine. So we've had some questions come in, which I'll go to now, and please do drop any questions that you've got either in the chat or the Q&A. So the first question is, why did my sexual needs disappear suddenly after chemo treatment? I feel terrible for my spouse. I just cannot get sexually aroused. It's as if that part of my brain no longer exists. Is there anything I can do to try and get back to how I was before? Yeah, so thank you for that question, because it's really honest. It's that sort of feeling of loss. And I think an acknowledgement of a change, acknowledgement that that part of your life has changed and something has been lost is really, really important. But I also hear in that, which is from that question, which is actually, I don't know what to do, but I want to do something. So I'm not interested, but I want to be, kind of, it feeds into that. And so I think that creating that space, both for yourself and for your partner as well, you know, starting with an acknowledgement of where you're at. So if you're in that kind of still fight and flight mode, then it's not unusual for that part of your brain to be completely switched off. You know, there is no thoughts and ideas about a lovely, you know, night with a nice movie and a bottle of wine, or a nice meal out. Not that any of us can do that at the moment, but you know, it's those sorts of things. Just acknowledging, where are you at, where do you want to be, and finding a space to create that sort of training camp. So it might even just be, you know what, we used to really like it when we did this together, we had a bath together, or I gave you a massage or something like that. So even non-sexual things that just create that space to be intimate, and that closeness can often help to bridge the gap as you start to progress things. That question was also about you know, just not feeling aroused, you know, even if you're trying everything. And I think that sometimes that panic mode of, well, we've tried everything we normally did and it just didn't work, why are you not interested, or why is there no response? And just reducing that panic, just sort of saying, actually, we're going to take it out of that space, we're going to try something different, we're going to do something different. And you know, I do think it starts a lot for women with women, so women understanding what they feel, if there's are changes, acknowledging if there's some discomfort or pain, what that makes them think and feel as well. So hopefully that gives you some things to explore there. Thanks, Julia. Next question, is vaginal estrogen, Vagifem pessaries, safe to use after having ovarian cancer and debulking surgery?
Yes. So it's, as I said at the beginning, it's you know, I caveat what I said with, you know, this is, I cannot be prescriptive in what I'm saying. It's not just for you, but in general, we know that the evidence is telling us that things are a lot safe, that those topical estrogens, particularly because they are the amount of systemic absorption, so the absorption within your body, but even then systemic HRT is a lot safer than we previously thought. So I appreciate there is other concerns for women, so women with a genetic predisposition will maybe more reluctant to use those sorts of things, so that's really key. But it's always a discussion with your clinicians about it. But yes, generally what I would say to that is, if you have a worry or a fear about using those things, and there are lots of other things. I work a lot with breast patients who it wouldn't be safe for, and we consider many different ways that we can approach that without using topical estrogens. However, you know, if you want to, then it definitely can help to alleviate a lot of symptoms, and it's safe.
Thanks, Julia. Next question, is Hyalofem available over the counter, or is it only via prescription?
So I believe you can buy it online. I have had many patients buy it online, and it's through a company called Purple Orchard. But the GPs, some, obviously, like everything, some GPs are happy to support a prescription for it. And on the Hyalofem website, there is all of the information for your GP, so how they prescribe it. And so it's certainly prescribable by your GP. It just depends whether that commissioning group are willing to support it. But I do have lots of women who do just buy it over the internet.
Next question, I can't get past the stoma bag on me. If I find it off-putting, how can I expect my partner to find me sexy?
Yeah, it's really hard to hear that, isn't it? Because it is really challenging. I know that there are some fantastic things that can be used. So specific bands or underwear that help to mask it, that are similar to sort of attractive underwear. I think that there are some real easy strategies. So sometimes the stoma represents something. It represents that lack of control, or, you know, the worry is, oh my goodness, what if we're mid-sex and it bursts, or, you know, that sort of thing, or what if it starts to blow up with loads of air. So I think if those are some of your concerns, then I think addressing those. There are, in the same way that you can buy the very, very small ones, bags that you can use to go swimming and things. Sometimes I find women prefer to have that, you know, if they know that they're going to have an opportunity for intimacy, they might spend a bit of time together, then have before they actually start to become more close or more physical, go and put the smaller stoma bag on for a shorter period of time, so that they feel a bit less like it's a big you know, it's a big bag sat there. The second part to that question was about how does my partner get over that, and I think that's also about communication. So, you know, it would be interesting to hear, and sometimes it is difficult because we give socially acceptable answers to each other, especially in relationships. So, you know, do you find it a problem with my stoma bag? No. You know, all of that kind of thing. Does my bum look big in this? But if you can try and create that space of, actually, it's not about whether you have an issue with it or not, it's, do you have a concern? What is the concern? In the same way that I just, you know, wanted to find out for that person, what is it about the stoma bag? And if it's just purely about the stoma, then there may be some work that you could do with the therapist around adjustment for that, because these are challenging things. They're not easy just to get on and over with, but sometimes there's an underlying concern that can be addressed that can really help to minimize those worries, and the same for your partner.
Thanks, Julia. And I've just put in the chat information from Colostomy UK about sex and relationships as well. And they've got some information and some publications around that. Okay, so we've got about 5 minutes left. If anybody has a question that they'd like to ask, then please do drop it into the chat now, the Q&A. This is your last 5 minutes opportunity to ask Julia some questions. But as I said at the beginning, do get in touch if anything occurs to you later on, then please do get in touch with us. And Julia, I just want to say as well, with just going back to the prescription question as well, some of the lubricants and things are available on prescription, aren't they? I know that, yes, water-based lubricant is available on prescription. So if people are worried about cost, and obviously with a cancer diagnosis, you don't pay for prescriptions.
Correct. Yeah, and you know, I think so. Yes, is definitely prescribable and available on the NHS. Silk, which is a vaginal moisturizer, is definitely available and prescribable on the NHS. So yeah, I definitely look at those things, and you're certainly eligible for any of those prescriptions as a result of the type of treatment that you've had of diagnosis as well.
Great, thank you. Okay, well, I don't think we've got any more questions coming in, but oh, here we go. Just as I said that, one popped up. Okay, someone's saying it's just nice to hear people talk about sex. Thank you.
Oh, that's great.
So we will come to the end, but Julia, was there anything that you wanted to say before we finish?
Only to say, you know, that how incredibly resilient the women that I work with are, and those who I think are engaging in this are as well. You know, you are fantastic at really voicing what your needs are, and I would just empower you to do exactly the same in this area. This is a part of your care, and you know, and you're doing an incredible job anyway, but please, you know, continue to talk about these sorts of things with your clinicians, because part of my role in my centre is doing a lot of education with clinicians, helping them to open up the conversation, helping them to feel comfortable about having these conversations. And I know how valuable and important it is to hear the voice, your voice as a patient, because that really helps to direct and guide services. And I would really hope that there'll be more and more services and more people, you know, who take up the training as I have to support you. So yeah,